to say in 2 minutes what this meeting's about. This meeting's about inequality, essentially. We call it variance, but that's a euphemism for inequality in access to healthcare. And I want to stress that when a lot of people say to me they thought this was all about variation in prescribing of disease-modifying therapies, and I want to stress it's not. So I'm going to put somebody on the spot who has an opinion about that, what she thinks the meeting should be about.
Thank you, Gavin.
Helen Ford?
Helen Ford from Leeds. Yeah, I am concerned about using variance in medical prescribing as a surrogate outcome measure for the quality of MS services. So I just think that there is a much bigger picture. I was really pleased when Gavin introduced it yesterday to think about inequalities in a bigger sense and think about the whole pathway for people with MS. So I think, you know, we should be thinking about people who are perhaps living in an area where there's a single-handed general neurologist, how quickly are they getting to see an MS specialist, about access to services, and also about variation in inequality across the UK.
So I think most of us would agree with you there. I think you're going to have no dissenters in terms of that. And then there was another person who came to me afterwards and said, that's all fine, there's a lot of energy in the room, but when people go home, nothing's going to change, so we need some leaders. So I'm going to put Gabby on the spot to say something about leadership.
Well, I think that in this room we're all assumed to be leaders when we go back to our institutions. And yet, in all of our training pathways, leadership and how we can align people, develop a strategy, motivate and inspire is something that we just have to figure out on our own. We often stumble and are ineffective. So I think that we have to really invest in developing leadership programs amongst people who are expert so that we can really have impactful change that is efficient locally. And the American Academy of Neurology does this very well, and I think that in Britain we are well suited to do the same.
So those are two opinions that came to me. But the other thing is I spoke to a lot of people last night, and people thought the overall consensus is that this is a very important meeting. I know it's exclusive in inverted commas because of resources. We had to actually limit the number of people who could attend this meeting, and there were a lot of people who wanted to come but couldn't come. And so the message we should send out to the community is this is a very inclusive initiative. It's not driven by neurologists or MS specialists or pharmacists or health economists. It's for everybody, so it's a big table. And I think for this initiative to be successful, we're going to have to bring in all stakeholders. Everybody has to be part of the solution. And so I'm not going to say much, just to say that the low-hanging fruit from yesterday was very easy. There's lots of other initiatives going on, and Adrian Williams was very keen that we engage with NHS England with anything we do, because they don't want to duplicate things. They want to partner with people. So you know, one of the outcomes of this was what can we do with NHS England, for example, and GIRFT, to address some of the issues. So for me, the low-hanging fruit yesterday was quite clear. We all need outcomes. And so we need a national outcome, we need to collect outcomes nationally, and we'll have to decide what that is. Part of that would also obviously be a national audit, and I think the only way it's going to work is if NHS England mandate that we do have a national audit. It's actually mandatory. If we want to look after people with MS, we have to collect data. And I think if NHS England can come with that mandate, that would be great. What tool they want us to use is another debate. So we don't want to discuss necessarily this today, the fact that we have to have an outcome and we have to have a national audit. That's two things. But I think you please, as the meeting rolls on, keep thinking, because we've got a very short breakout sessions this afternoon to come up with potential solutions to this issue. And I would like everybody to be more engaged in terms of questions and discussion. So I'd like the speakers to, I want the speakers to realize we don't want you to use up all your time showing us slides and data. We want shorter presentations with much more time for discussion. So I think that's where the benefit is. So coming back to the variance inequality question, I'm not going to take up my whole half an hour, so I want to give over the microphone to two people that have been working with David Rogg on inequality in access to healthcare. And the first is Hazel Rodham and Paola Dey. They're both professors of One is a professor of health and social care, and Paola is a professor of public health and epidemiology in Edge Hill, and they're going to talk to us about the scoping exercise in relation to poor access to therapies.
Okay, thank you very much for letting us speak today. I just want to present a piece of work that we did that was funded through Salford. Okay, so you've talked a lot about variations. Then we have to think about what's avoidable, and where those are avoidable, what contributes to actually inequalities in health experience. And it's not just what we perceive as outcomes, it's what patients themselves perceive as outcomes. In other areas, as in MS, there's some evidence that where you live and your socioeconomic status actually does affect patient outcome. In part, we know that access to disease-modifying therapies for some patient subgroups has been due to access to how services are organised. But we need to think about those inequalities, as just been said, right across the care pathway, from prevention, lifestyle modification, right the way to welfare. So this scoping review actually investigated intra-national variations in access across the care pathway in health systems for different inequality groups, and we limited it to adult MS patients. So when thinking about inequality groups, particularly when we're doing a scoping review, we had to have some framework. So we used the Cochrane Inequality Groups framework called Progress, which we can then add to in terms of disease-specific inequality groups. So Progress includes residence, ethnicity, employment, gender, religion, education, socioeconomic status, social capital, however that is defined. And when we thought about it, we thought there are other potential inequality groups in MS, age, disability, disease type, mental health conditions, and vulnerable groups, such as people with learning disabilities, travellers, migrants. When we thought about what services we wanted to think about, we categorised them from the primary prevention through to, which were like lifestyle services, secondary prevention like screening, through to rehab services, through to information support. And within that, we were able to put some subcategories according to the papers that we identified. So the papers we identified included adults with multiple sclerosis, any type or stage, any time following diagnosis. We only wanted those papers that compared MS subgroups, not MS patients with population or other disease groups. And we only included in this particular scoping review studies with a quantitative design. You won't see this, but just to say we identified from 6 databases 5,000 papers, which we then whittled down to 36 studies which fulfilled the criteria. Right. What did we find in those 36 studies? Well, they were mainly from the US and all were from the US or Europe. There were only 3 from the UK. These are peer-reviewed publications. Only 3 had a cohort design and only 4 were population-based. Many were from the same data source. So a lot came from the US Multiple Sclerosis Society, from NARCOMS, and all had been published since 2000. So we think it's a growing area of interest. So what was most commonly investigated? Gender, age, disability. There are a number of others that were commonly investigated but are very specific to the countries. So race, but they were mainly US studies, so mainly African-Caribbeans versus Latinos versus Caucasians. Place, urban versus rural, but we're talking about the US, so rural there is quite different from Cumbria or, I can't think of any that were rural in the UK. There you go. And social capital here was mainly defined as marital status or living arrangements. What wasn't, where we found no studies were amongst the vulnerable groups and religion. And again, a lot of the studies were around MS services, access to DMTs, around rehabilitation. We found nothing about access to welfare and nothing about informational support. And very little about prevention, which is particularly interesting given the focus on exercise and smoking cessation. So very inconsistent across the studies, but if we're to give a broad statement, there was a trend for inequalities amongst men, older age groups, people from lower socioeconomic groups, non-Caucasians, those with mental health problems and those in rural areas. But this is complex. Okay, so there are specific times when, for example, women were less likely than men to have access to services, for example, seeing a urologist in one paper or having access to a powered wheelchair in another. There were instances where younger people had less access, so for example, receipt of personal assistance. There were ones where there was inconsistencies, so amongst the studies around access to DMTs, older people and people from lower socioeconomic groups had less access, but there wasn't differences between races or genders. And some of these papers are starting to get old as the context changes. Disability was particularly difficult to interpret. So there was less access to prevention services amongst those who were disabled, similar access to MS-specific services, and more access to things like assisted living. So you might think that actually the last that I said, actually that goes with what we would expect. Access to MS-specific services, if there's no inequality, that seems good. But actually, there was also less access to neurology services. So what's happening there is, should we expect more access to more specific services? So, conclusion, yeah, there are inequalities, but they're very context-specific or service-specific. So you can't assume that because there's inequalities in one area, that same inequality will happen. And we have to know not just that there's a variation, but why there's variation. What are the reasons, and are those reasons important? Very limited UK published data, lots of studies with inadequate methodologies, so very much focusing on cross-sectional studies, which doesn't really allow us to see that relationship between the exposure and the outcome. And there are important gaps. So there was nothing about vulnerable groups. And while I will always think that the patient voice is really important in here, but it's important to realise that some patients don't have a voice and some groups don't have a voice. So it's important to make sure that there's equity in what we listen to in terms of patients. Okay. And that's, if you want to talk to us more or learn more about the study, there are details. Thank you.
Any questions? I mean, this is a major topic in mental health. Inequality, particularly around social isolation, and how social capital gets trimmed with the diagnosis, and how people do very badly depending on how big their social capital is. Any questions? Yes, Sean.
What we've noticed, Sean, neurologist in Sheffield, what we've noticed locally is that the really poor provision is for the most disabled group who can't get to hospitals and are now working with the palliative care group and looking at things like, can we have telemedicine models and things like that to try and help those groups, and also sort of agreements that our MS nurses can go out and just come and speak to us to give management plans, those sorts of things. And those are a completely invisible group when you look at this data. And I think probably the most vulnerable group, yes, we have patients who've got learning difficulties and things, but I don't think those are quite such a large group or quite such a poorly served group as the sort of late, very disabled group.
Yeah, as long as we know that I think we can't make assumptions, particularly as people with learning difficulties. That cohort is ageing. They're living longer. So while I agree with you, sometimes it's the small groups who do suffer, so we can't ignore them, is what I'm saying. Yeah, and make assumptions.
Thank you. One of the difficulties our patients tend to have is the threats they're continuously having from PIP withdrawal in the UK. And because of this, the default mechanism is that all patients have to be reviewed, and therefore they're denied for benefits until reviewed again. And usually the people who visit them end up coming to say they are able simply because they talk to them without even an assessment. And a lot of them will then be out of finances to look after themselves for months before going through the appeal processes and things like that. Do you think there is a way that we as a body can actually educate the PIP community or the social services to actually review this and not use it as a default mechanism in the UK, because it's really upsetting patients?
I think that goes outside my knowledge. I don't know if anybody else.
Well, this is something that the MS Society and the MS Trust and the patient organizations should partner with the professional organizations to lobby. It's a political issues, and it's not unique to MS. It's not unique to MS. It's about disability in general. But that's a political issue.
I wondered if you came across Lauren Rolak's work on this from Wisconsin. He did some really interesting work on outcomes comparing people who were insured versus non-insured in the United States.
I mean, we start, in terms of, I'm not sure if we started when we started this scoping review, we wanted two sections, one that looked at outcomes and one that just looked at access. We did find some papers around the US health system about access. When we started to look at the outcomes, it was really difficult to interpret that, because there are a lot of papers around about around what we call inequality groups and outcomes, but they're also included, those characteristics are included in papers that are also nothing to do with inequality, but are about outcomes. So it got quite difficult to actually do that as a scoping review. We did come across some papers around insurance.
Well, he discovered, and it was really good work that he did long back in the end of the 2000s, was people who had insurance and had access to the best medications against people who didn't have that. He followed them up regardless. And he followed them up for a long time, and it made no difference, which was very interesting. And it would be, I think, I'd really push you back to his work to go and have a look at that. So Lauren Rolak's work, it was really brilliant work that he did. And it was sort of, for some reason, didn't reach the publicity it maybe should have done, I think. But if you're looking for comparisons, I think that's a good place to look. Wisconsin.
Neil?
I think it highlights how embarrassed we should be about the lack of data in our particular patch of the world, having only 3 studies. I hope that our study was one of those, actually, that you talked about with ethnic minorities. And it's in an area where we actually have quite a rich demographic data source. We can do this considerably better than the Americans can, I should say, because the data is certainly available. So we should start to put resources into that, and I think that's important. The other comment I wanted to make was that increasingly in the UK it seems that we are centralising these specialist services. And I wonder whether you came across any data which examined distance to centre in terms of outcomes. And I would point out that there are a few more rural places than the Lake District in the UK.
I apologise.
And this, I know this meeting really has emphasised NHS England, but you know there is NHS Wales as well, and some bits of Wales are fairly rural, and some bits of Scotland are fairly rural as well. So we have an opportunity, in a sense, to look at that geographical remoteness as an outcome index for patients, and that might drive change or at least a sort of compromise between centralisation and providing services in more distant parts of the UK.
Yeah, and you know, I didn't come across anything that did distance, came across stuff that broke it down a bit more into city, inner city, etc. But I mean, it's also a state of mind. So we find locally, I don't know if you find that, people from Bolton won't travel to Wigan, yeah, even though it's 10 miles. Yeah? Something to do with 1910 and pies. But, that distancing is important, but it's also putting that into context of the local communities as well.
We don't have the pie problem.
Yeah.
But there are actually very good NHS data around for big centres about distance to travel between all major centres in the UK.
Yeah.
So that kind of data would be available too as an outcome measure and should be actually looked at.
Yeah. And sometimes it's not just distance, it's travel routes.
Yes, exactly. So it's time to travel.
Yeah.
It's not necessarily the distance.
Yeah.
Yes. Where's Neil McDoodle? So we went up with the Glasgow group to Stornoway in the Hebrides earlier this year, and you want to talk about travel problems. Getting from the islands to the main centre is an enormous hurdle for people with MS. Just the annual consultation it's like a mission for them to travel from Lewis to that's people in a relatively well serviced island, actually. I hate to know what it's like in more rural islands than that. Joella.
So the King's Fund brought out a blog yesterday about health variance in the NHS, and that's wider. And the big quote that stands for us is that people who live disability-free lives, their life expectancy for that is 71 years in Herefordshire and only 55 years in Tower Hamlets. And that's Whitechapel, that's where our hospital is. That's a massive difference. And obviously disability-free lives in MS, that's something that we can be measuring. But also, do you think that social prescribing is something that our community should be doing to help patients? Things like going on walks and things like
Absolutely.
that. And how do you think that we as a community train each other to do that?
That's a big question, isn't it? I mean, we need to develop social responsibility a lot more. We need to bring communities together. But we also need to give them information about what can happen and why you're doing things. Yeah? Not just expect it to happen. Yeah?
Yeah, so social prescribing is a very important issue. So, in our centre we do a lot of public engagement. We have research days, we have people coming up for co-design and all this kind of thing, and it's pretty obvious that people that engage with us from a social perspective just do so much better. I haven't got data for this, and we are going to start collecting data. Where's Saul? Is Saul here? So we've got an ECTRIMS fellow who's going to be with us for a year, and his whole brief is to study exactly this, how do we as a group create programs to increase social capital, because social capital is probably the most powerful predictor of outcomes across many diseases. It hasn't been studied formally in MS, but I assume one of the things we should be thinking about is how do we incorporate social prescribing into our treatment model. Any other questions? Can I all recommend, earlier this year I think it was, there was a drama on BBC4 called An Act of Kindness. Who listened to that drama? So it was about a very sad story of a woman with secondary progressive MS who lived in Bradford. And her husband, who is an actor, she was an actress, wrote the drama and was dramatized. And she went off to Dignitas to have an assisted suicide. And it basically tracks her life from diagnosis and how her social capital got cold and she became socially isolated, living in a flat above a car park in Bradford. And we had it on the blog, and it generated an enormous amount of discussion and debate about this. And so we needed to also put so Alistair Coles wrote a beautiful response to the program from a religious perspective. And we got one of our, a woman who works with us, Rachel Horn, is a journalist, wrote MS perspective, and I wrote a thing from a neurology perspective, and it's worth reading those posts and listening to that program, because it kind of tells you what happens to people with MS as they become more socially isolated, and that's a big elephant in the room. Now, we're talking about access to disease-modifying therapies and diagnostic things, but it's at the end of the journey that it's really, really poor, our services in looking after the most disabled people. And the tragedy of this, if this woman had been picked up and had social prescribing, etc., there's almost certainly she wouldn't have needed to go off the Dignitase, because that was the solution to her problems. So David, I don't know if you want to mention anything about your new, you're going to talk about it later, about the more disabled patients.
I'm going to talk about it.
Okay. All right, any other questions on that topic?